Thank you very much, dear Dr. Latsios. Thank you all. I would like to thank Dr. Sparias for the kind invitation. And I will start immediately with my case in order to be fast because time is always very precious. So, okay. Our case is about a young male, 58 years old, obese, as you can see, who was a heavy smoker in the past with COPD, a hypertensive patient who experienced stroke in the year 2020, but without any important sequels. And he had poor mobility due to orthopedic problems. The aortic valve stenosis was presented in his life with an acute pulmonary edema due to LV dysfunction. He took medical treatment for several years, and he had a favorable evolution of his disease. But after some years, he had worsening dyspnea with New York class 3. His ECG was with a sinus rhythm and signs of left ventricle hypertrophy. From the TE findings were that he had left to right type 1 bicuspid aortic valve with a good injection fraction. The left ventricle end diastolic diameter was 56 millimeters. The aortic valve area 0.6 square centimeters, and corrected to the surface of his body was 0.35. The peak velocity was 4.9 meters per second, and he had a mid gradient of 56 millimeters. Systolic pulmonary aortic pressure was 35. The coronary arteries had nothing important, no significant lesions, and his Euroscore 2 was 5.7. As you can see from the measurements from the CT, he had a large sinuses of Valsalva. The annulus, at the level of the annulus, the perimeter derived was 32 millimeters. At the LVOT was the 33.3, a little bit larger. And 4 millimeters above the annulus, the intercommissural distance was 31.7, and higher at 6 millimeters was 30.6, and at 8 millimeters 30.6. So as we can understand, there's a conus-shaped aorta. You can see that the origin of the right coronary artery was unusual. He had an unusual takeoff, which is very frequent in those patients, and that confirms also the bicuspid anatomy of this patient. You see that the height of the arteries is good enough, 17.6 and 17 for the left. And the ascending aorta is the perimeter of the ascending aorta was 40. It's not very big. The angulation of the aorta and the left ventricle is okay. It's not an horizontal aorta, and you see that the distribution of calcium is symmetrical. There's a lot of calcium. And it is symmetrical. There are nothing important. Everything is okay in the lower limbs and the abdominal aorta. This is the summary of what we have said. This is the situation. Young patient with bicuspid aortic valve, conus-shaped conformation. That's it. So this patient does not meet the criteria of unfavorable bicuspid anatomy for TAVI, because, for example, he doesn't have an elliptical annulus. The calcium distribution is symmetrical. From the other hand, he doesn't have any calcification at the level of the LVOT. The coronary ostia, they have a good distance from the annulus. He doesn't have evident aortopathy, and he doesn't have also an horizontal aorta. What we have considered and we discussed with our heart team was that he was a really very young patient. His age was under 65 years old. He was a good candidate for mechanical valve. He didn't have an extensive coronary artery heart disease. He didn't have aortic dilatation. He was 4 centimeters, his aorta. He didn't have multivalvular disease. The calcification pattern was okay, with low risk for annular rupture. And he had also low risk for paravalvular regurgitation. And of course, as we said before, his iliofemoral anatomy was favorable. With respect, also with what the patient wanted, we started to think proceeding with TAVI and with a balloon expandable valve with a Merrill 32 millimeters. From the aortogram, you can see that the ostia of the carotids have a bovine configuration. We said initially we thought to place a sentinel in order to protect him from strokes, but it was really difficult. So we said to avoid manipulations in this area, and we abandoned this. You can see the aortogram. He has also a good regurgitation. Okay. We started with pre-dilatation of the valve with a 25 balloon. You see also that okay, with the contrast injection. Excuse me. Okay. Play it again. It was 25 balloons, okay?
Please speed up a little, Vios, because each one's got 5 minutes.
Okay. And this is the implantation of the valve. Oh, I'm sorry. You see that the inflation of the balloon is not, oh shit, sorry. You see that the inflation of the balloon is not symmetrical in both sides of the valve. It starts from the aortic part of, come on, from the aortic part of the valve. I'm sorry. And at the end, the balloon pops out of the valve. Okay. So now we have this situation that the valve is in place, but it's not expanded at all. what we have done, we have placed the same balloon immediately, a little bit deeper, more in the left ventricle than in the aorta, and we expanded the valve. You see that the expansion is nice into projections, and you see that the position is good, and there is no any regurgitation. The problem with those patients is everything. If everything goes well, that they may need at least another valve, maybe two, till the end of their lives. And anyway, to perform a TAVI in bicuspid aortic valves, even if the anatomy is favorable and everything seems to be okay, we have always to remember that bicuspid valves are problematic and they're full of surprises. Thank you very much.
Thank you, Dr. Tzifos. Very swiftly, we go to comments.
Very nice case. It underlies the importance of measuring at intercommissural distance. Although it's less than 20% tapered anatomy, that was such a case. We would have considered a self-expandable valve.
Yes, but we thought that due to the anatomy or to the size of the valve, we preferred the balloon expandable valve because we thought that we have better radial force, and we preferred the balloon expandable valve.
Okay, that's a very nice question. If I may engage the audience, can we vote who would go for a self-expanding valve? Hands up. Who would go for a balloon expandable valve? Hands up. Who would go for surgery due to bicuspid? Also hands up. Okay, so they are equally divided. So we have to hurry on. Thank you.